Hello everyone, my name is Dr. Ferghal Armstrong and welcome to this episode of Cracking Addiction. And today we've got the good Dr. Matthew Frei with us. Matthew, how are you?
I'm well. How are you, Ferghal?
I'm good. So for the benefit of the listeners, can you describe what your job role is?
So I'm an addiction medicine specialist, a fellow of the chapter Addiction Medicine of the College of Physicians, and my job for some time has been as an addiction medicine specialist. In a clinical leadership role, I'm the clinical director of a large alcohol and drug service in Melbourne, Turning Point.
Yeah. So one of your specialties is actually helping practitioners, prescribers, who find themselves in difficulties. Could you let us or talk to us a little bit about what that actually means?
Yeah, so it's something I became interested in early in my addiction medicine career, and it is really about helping doctors with dependence or addiction. And the reason it's an issue or a subspecialty within addiction medicine or within healthcare is because doctors are notoriously bad at getting help for all sorts of problems, but particularly those that may have a negative impact on their reputation, their income, their occupation, and as you may know, using illicit drugs or using drugs illicitly has got a huge negative impact on medical practitioners, on health practitioners generally, on anybody. In fact, it's not.
Yeah. Yeah, I mean, addiction is a devastating illness. It's a chronic disease, as we both know, and it's got a devastating impact on the lives of both patients and their families. But I mean, I'm reflecting on the issues around addiction in the medical profession, and it's similar to any other chronic disease, isn't it? There's a huge stigma surrounding doctors who get sick, and especially with mental health. And even more so with addiction, would you not say?
Absolutely. I think it's pretty much still the lowest of the low in terms of diseases that you don't want to have, in terms of what it does to your standing with people in the community, with society in general, and particularly doctors. I mean, the sense is that doctors should know better, that they've got all this knowledge about drugs, so why would they use drugs? And possibly the opposite is true. One of the reasons doctors, I think, use drugs that has been established is this sort of faith in the value, how effective drugs are, because they're part and parcel of what we do every day. So they're a very big part of our professional life. So there's this sort of overinvestment in the worth of drugs, I think, in some doctors.
And we have to acknowledge the fact that being a healer, being a doctor, being a nurse, being an allied health professional, being registered with AHPRA, any of those professions are very stressful. It's there's an enormous pressure amongst our craft group to actually perform at the highest level constantly. And given the COVID outbreak and how we've had to deal with that, I have enormous amounts of sympathy for people who find themselves suddenly caught up in this. I mean, do you think that COVID has impacted upon the health profession in terms of the prevalence of substance use disorders?
Look, to be honest, I don't know, and I think it's probably too early to have a good sense of what it's done to specific groups in the community. If it's anything like what it's done to the rest of the community, it's quite possible. And I think it's worth pointing out that doctors, the prevalence of substance use disorder in doctors is actually about the same as the general population. So there's sometimes a sense that we're more prone to addiction than the general population. And it's about the same, which is significant, of course. But the difference is with doctors is a few differences. One of them is that doctors, as I went at initially, they're very bad at seeking help. They're very late to go present, and we know just about any disease, including mental health conditions and conditions like addiction benefit from early presentation, from early treatment, early recognition and management.
But given the regulatory framework around presenting, is it any wonder? And can you talk to us about the regulatory framework?
Yeah, so our regulation authority, which regulates a number of the health professions, the Australian Health Practitioners Regulation Authority, AHPRA, have a job to do, and the job that they do is protect the public, protect the reputation of the professions, and the job they're not really mandated to do is to look after doctors per se. They're not a health service for doctors or nurses or any other of their professional groups. So that in looking after the public, in protecting the public, if you like, against possible impairment from a health practitioner or a medical practitioner or the health practitioner, the first move is usually to pull that practitioner away from the public, to stand them down from work for a while. And it's really not a consideration if you're depending on your work for income or any of the other hardships that come from losing your job. Sometimes, very rapidly after somebody notifies AHPRA about a concern, they're not concerned about that. Their top priority is protecting the public, and if that means the doctor's going to suffer as a result, then so be it. And that's an honourable and a reasonable motive to work under, to protect the public from harm. I think there's nothing wrong with that, of course, and we need a regulator that protects the public. But there is some significant fallout, and I think we've got to be cautious about seeing things in the long term or the medium term where actually significantly damaging the profession will, I think, potentially have far-reaching effects, not just on the index doctor, if you like, or the index practitioner, but there's a flow on.
So tell us a little bit about mandatory reporting, because that's something that troubles my soul sometimes.
Yeah, so I'm not an expert in mandatory reporting, and the reason is it's changed a bit. But initially, it was, as you say, it was a reporting that's mandatory, which means that if you're a colleague practitioner, another health practitioner under AHPRA, and you observe a practice or behaviour or anything that you think might harm the community from a doctor that's impaired or affected by disease or mental illness or anything, then it doesn't matter if this is the principle behind mandatory reporting. It doesn't matter if you're that doctor's treating practitioner. If you're involved in a therapeutic relationship with the doctor, you have to report, or you're meant to report that doctor to make a notification to the board about your concern. And if you don't, there's potentially consequences, and that was built into mandatory reporting. Now, where it gets a bit cloudy for me is I know that has been softened, and that it's perhaps not quite as severe and sort of big stick like as it was. But there's still an expectation and a requirement, not just a moral one, a legal one, I gather, to report people, to notify AHPRA of people that in the profession who are of concern.
And I think this is one of the barriers for doctors to seek help for any condition, but especially mental health conditions and addictions. The minute you seek help, certainly in Victoria, the person that you seek help from is, or at least to my understanding, is mandated to actually make a notification to AHPRA against you. So that's one of the barriers to accessing healthcare for the impaired practitioner. Would you not agree with that?
You're absolutely right. You're absolutely right about the expectation of the treating practitioner, and absolutely right about what the consequence is.
Yeah.
I think a lot of us would reinterpret that and look at it, in a sensible way, which is that the ultimate goal of everything that the regulator does is to protect the public. Now, you can effectively protect the public in most of these cases if you get the doctor to stop working if there's a concern. If you're concerned, uh, take action by getting the doctor to stop work voluntarily, and engage them in treatment, and take it from there, and review and reassess regularly. And in most cases where there's impairment, whether it's mental health issues or it's substance use, that is quite effective. And in fact, the idea that this is going to be contained without involving the regulator is actually quite a motivator for people to engage in treatment and to cease work, of course. So that's now sometimes you can't do that. Sometimes you can't get a handle on whether they're going to work or not, or you're uncertain, and you might be concerned that the public's being put at risk. And look, sometimes there's no choice but to contact the regulator. It's virtually never happened to me, but it does happen, and a lot of as a result, a lot of people that I see have already been in contact with the regulator, and not in a positive way.
Yeah, I mean, I've got some experience of treating doctors, not for addictions or mental health issues, but just generally. And, I'm just reflecting on, listening to what you're saying, I'm also reflecting on my own personal response to seeing someone. So when I, in my hat as a GP, when I look at down my list and I know that one of my patients is a doctor, I'm a little bit apprehensive. I'm wondering, am I going to be judged about the standard of care that I deliver? And also, am I going to get involved in a mandatory reporting scenario? Because even with patients who are not medically qualified, this concept of mandatory reporting, especially for driving, it creates a therapeutic barrier, I reckon. And I think it's even more pronounced when you're looking after a patient who is medically qualified. So, given that I don't have any experience of looking after a doctor who is impaired by virtue of drugs or alcohol, what does it feel like from your position to provide that kind of care?
I think the feelings that you get, the sort of self-talk and the way we feel when we see colleagues is probably fairly universal or very similar in many people, and certainly the sort of sense that you describe of feeling like you might be being assessed, and that your patient might be more skilled medically than you are, and it's humiliating and embarrassing and mortifying to try to treat this person. It's not uncommon, and it's why to some extent treating doctors is tricky. We make crap patients, and not very good at treating our colleagues. In some cases, or it's challenging to treat our colleagues, and some people do it better than others. And what happens as a result, I think, in fact, I'm seen this so many times that I'm convinced it's the case, is that while doctors can often get treatment, they're late at presenting for illness, but they can access treatment. We're very health literate. We've got colleagues and contact with the health system. We're pretty good at interacting with it. So doctors can get treatment. It's whether they can get good treatment. There's plenty of treatment they can access, but it's often on their terms, on our terms, I should say. It's often when we want it, but a kind of a bit our own doctor and a bit, using another a professional for stuff that we can't do to ourselves or can't do ourselves. So again, that's where we make poor patients. And I think what I tell doctors if I'm talking to doctors, and I used to do a lot of it talking to either junior doctors or undergraduates, is that, get yourself a GP. Don't try to second guess your GP. There's no need to just pretend that you don't know anything and, talk like, feign ignorance about the medical stuff that you know. But I think it's discomforting for everybody if you're trying to second guess your doctor. You're talking about research that you've done on your condition and you think this is the best treatment. And that does happen, and it's makes it incredibly difficult, I think, to give good treatment to somebody who's kind of dictating your treatment. We've got to put ourselves in the patient role in these settings, and there's some of us are better at that than others. Some are fantastic at it. Some people are really, really good, including people I treat for dependents. They're really absolutely fine about saying, look, you're the doctor. I might be a specialist in some complex area and a professor or whatever, but in this interaction, you're the doctor, I'm the patient. I'll just do what you recommend. A lot of them will question what you do if they want explanation or rationale, but the good patient doctors, that's the rhetoric they use in the talk that they use.
So when an impaired practitioner comes to you, you're saying to me that it's usually because there's been already a referral from AHPRA. So in your experience, the doctors that you treat, how has AHPRA come to know about them?
It's invariably the notification system. So it's the system where the individual, whether it can be the drugs and poisons, the medicines and poisons regulator in the state of Victoria will make these notifications. It can be a patient, it can be a patient's relative, it can be a pharmacist in a community pharmacy, a high street pharmacy. It's usually the people that have observed something of concern, and so the pharmacists are common to report doctors using drugs, as are the scheduled drug regulators authority like our drugs and poisons or medicines and poisons, and you can just write one can just write a notification to AHPRA and submit it. It can even be submitted anonymously, but it's anonymous not to AHPRA but to everyone else and the doctor that you're notifying on. And it's as simple as that. And whether we like it or not, AHPRA treat every notification on its merits and will investigate to some extent most notifications, regardless of who they come from or what they are. In my experience, I'm not. I don't work for AHPRA, and I'm just going on what I've observed of the notification system, and that makes sense because they're about protecting the public, and I think it's about giving every complainant or every notifier the benefit of the doubt and just establishing what's going on, even if it's on fairly tenuous grounds that the notification's being made.
And I think would it be fair to say that most doctors whom you see have an optimistic hope that they can get better and recover and get back to practice? I mean, is that, in your experience, is that a usual outcome amongst the cohort of the doctors that you look after?
Look, I think it does vary a bit, and there are some who are incredibly depressed about what's happened and have lost a lot and may not see, because of depression, any hope at all. They may be quite despairing of their future. Fortunately, that's unusual, but it certainly happens. I think they're really probably pretty similar to the mainstream public, if you like, or the lay public, or whatever we want to call people that aren't doctors, aren't health professionals. Some people are very motivated and are confident and hopeful and optimistic and so on, and others are a bit less so. I think what's a good bit of information that I always give doctors that I'm treating early on and reinforce it intermittently when I can is that while doctors are late to present for treatment and can sometimes make poor patients, they are overrepresented in the success stories or the outcomes of treatment. We're in the much higher levels than the general public, and some of them, of course, it ends very badly for some doctors, and doctors do die of this condition. But in general, people that engage in treatment for substance use disorder that are doctors tend to have very high outcomes that we don't necessarily see in other groups. And there's a number of explanations or reasons why that would be so. the health literacy I mentioned earlier, the ability to access the health system, but also the resources that many of us are fortunate enough, are blessed enough to have around us, like family, a bit of money, and that we know that helps even in a very well underwritten health system like we have in Australia, and a very strong, it needs to be said, a very strong motivator to get well, which is once you're well, you get back to work, you get all the rewards that doctors get, the prestige and the money and just being in a job, of course. And many of us are de-skilled to the point of only being able to do medicine, and there's nothing wrong with that. But that's our identity and that's our life, and to not have that threatened or taken away is a real devastating situation to be in for many of us, and to be able to get it back is a very we're very fortunate. We're very lucky that in most cases, by doing the required things and engaging in some sort of therapeutic program, we can get back to work. It's not the end of the world in most cases.
That's a very good message of hope, isn't it? That for doctors who are impaired as a result of addictions, when they come and see you, most of them get back into the workplace.
Absolutely, that's the majority, for sure.
And how long is that time process? How long does it take to get back to work?
It varies. I mean, I don't. For somebody that does the right thing and engages in a recovery or a program that is able to be established by some sort of objective monitoring, and it can be presented as something that is going to minimise the risk or very, very low risk to the public when you're being tested 3 times a week for substances. That group shouldn't be really out of being able to work for very long at all. But I mean, months is probably a couple of months is probably sometimes the maximum that you'd expect, or around the ballpark of what people might be off work for. It depends, though. Some people are a bit late to engage, and might want to use the time to reflect a bit, and are in no big hurry to get back to work. In fact, others are just desperate and will do everything, go through every hoop they need to do the right thing to satisfy the requirements that AHPRA has, that they're safe and low risk to return to practice. And it doesn't take that long. I mean, it's not, and I don't think it's about the time off, the break from work, the mandated time off from work. It's I think the real challenge for doctors is maintaining that motivation and in keeping on going when the requirements of monitoring by the regulator are really quite onerous.
Well, thank you, Matthew, for your pearls of wisdom on this subject. I hope that our listeners are receiving this message of hope, that it is possible to recover from this chronic illness and get back into the workplace. But Matthew, I really look forward to chatting with you again very shortly. Thank you. That's all for today's episode. My name is Dr. Ferghal Armstrong, and you've been watching A Cracking Addiction.